Imagine you're a 68-year-old female and your right knee is sort of notifying you that it is quitting on you. Hurts, wake up in the morning, it's really stiff, and you're pretty tough. You get up and you play through the pain, but you're talking to your orthopedist, and your orthopedist is basically saying to you, hey, when you're ready, total knee will really help you. But it's up to you. It's an elective surgery. But if you look on the x-rays here, you got bone on bone, and it's just a matter of when you're ready. We can help, right? And so you go through physical therapy, and you go through the rest of conservative treatment, injections, and you finally decide you're going to get a total knee done. And you go in, and you have surgery. It goes really well. You wake up, and you actually get sent home the same day now, right? Maybe you have it done in an ambulatory surgery center. You're otherwise healthy, and you go home, and your husband takes you home in this case, or your kid, whoever it is, takes you home, and you are now at home because we know it's safer at home than it is in a hospital. Ambulatory surgery centers aren't built for that. This is the new wave, right? So you go home and you do exactly what the doctor says. You're working through your post-operative rehab. You're trying to get range of motion. You're trying to get back to normal gait, they'll call it, right? But you have no idea what normal is. How could you possibly know? This is your knee, and it's the first one you've ever had done. So the doctors and physical therapists and physician's assistants, they all know what normal is. But this is you. What's your normal? How would you know? So the next day, your knee's sore, and you don't even want to look at that surgical wound. But you don't know what's normal. So you start to get nervous, or your kid or your husband says, hey, is that supposed to look like that? Or how are we doing? How do you feel? And it is very subjective in a person who is, don't take it the wrong way, ignorant, right? How would you know? And you start to get nervous. So you call the office, and the person says, oh, no, that's normal. You're okay. And you're fine. Sounds good, right? The next day, it's still stiff. You're doing it. You're doing what the doctor says. What did the doctor tell you? Can't quite remember. Not exactly sure. Don't know. And am I supposed to be able to go up steps? How am I progressing? And you're not going to see your doctor again for probably 2 weeks. But he or she said, hey, call anytime, whatever. But you don't want to call the doctor. You don't want to bother the doctor. They're very important. So you're not sure. So you email the office through the patient portal. Or you reach out again. They say, oh, we'll have the doctor call you. And the doctor calls you and says, oh, take a picture of it. Send it to me, whatever. Doctors are great about this. Doctors really do care. But you really, in the back of your mind, are like, am I doing okay? Or man, maybe I'm doing really well. You have no perspective. And our next guest today is trying to help with just that. Now, there's all sorts of really cool stuff on the backside you will learn about that hospitals and doctors should know all about, health systems and insurance companies, because my next guest is one of the most interesting people in medical device and definitely in orthopedics, and he's an outsider. But he has created Canary Medical, which is a smart knee implant. So imagine part of the implant that is in that 67-year-old female's knee, once a day, is telling your doctor, feeding to your doctor, hey, range of motion looks really good. Gait looks really good. Balance looks good. All those measurements that they then come in 2 weeks and come in and say, hey, you're doing great. And they have perspective because they've done 8,000 of these. This is your first. They know, but the gap between them, Canary Medical answers. I love this technology. I'm going to need a total knee someday, soon. And I want to be able to look on my phone on the Canary app and go, hey, I'm doing pretty well again compared to people just like me. I'm actually doing better. Or, I'm falling behind. Fascinating. And all it does is just part of your normal implant. You don't ever even think about it. But your doctor gets all this kind of information. And if you start to get some of those signals that, hey, you might have an infection, or hey, you're not progressing the way we are, or this implant is loosening, wouldn't you rather know now than 6 months downstream? The answer is yes. One of the few ways you can actually do it intelligently is with Bill Hunter's product, Dr. Bill Hunter, CEO and CMO of Canary Medical, with his smart knee implant that I think you might find fascinating. Here's my interview with Bill. And thanks, Bill, for coming on. So, Bill, you're talking to your buddy Cope. You're sharing like a backyard. We're having a beer. And I say, hey, so, Bill, what is this thing? What is this thing you have for total knees? Explain it to me, because my dad just got one or whatever. How do you describe your product? We'll call it the Persona IQ, that smart implant. How do you describe it to your neighbor?
Yeah, I mean, I'd probably start by saying, are you familiar with glucose monitoring? And if they said yes, then I'd use that as my analogy. If they said no, I'd probably go a little bit further backwards. But
okay,
I'd say, look, right? We learned a while ago that getting your blood sugar continuously makes it easier to manage you as a diabetic than doing a finger stick here and a finger stick there. And what that allowed us to do was to keep your glucose within a nice, tidy range. And that's better for your health than bouncing around all over the place, doing it, a couple times a day and hoping for the best. And that was a pretty substantial move forward in that treatment. Well, the same's true when you recover from a major surgery, like knee surgery, right? You want to keep right in this band of normal activity. You don't want to do too much. You don't want to do too little. And you want to make sure that your readings are where they need to be so that you can adjust on a day-to-day basis and get better and better and better in a very predictable way. And so in its simplest form, that's really what we're doing. We're saying, hey, it's 5 days after surgery. What should I be doing? Because most people have no idea what that is.
Right.
And it's 25 days after surgery now. Can I start doing more? Am I doing too much? Am I doing too little? And where should my knee be? And what are my exercises? How should I be doing that? And, last but not least, I love to run. I'm not very good at it, but I do love it. And I would never recommend just showing up at the start line of the Boston Marathon, right? You want to kind of build your way up to that in a very specific way. And you want to look at your performance and you want to move it along so you don't get hurt and you successfully train yourself into a better position than when you started. And that's really all this really is. It's a guide. It's a rehab guide, but it's a rehab guide from your body, your readings, telling you how you are recovering, your expectations, right? I'm not Kenyan. I'm not going to try and go for the 2-hour mark. I'd like to just finish. So I need to know what my times are. I need to know what my capabilities are, and it needs to be titrated to my abilities and my age and everything else. And it takes a little bit of the thing out of it.
Yeah, you sort of naturally led to, intentionally or not, sort of almost like a performance, the way somebody's thinking about their performance post-operatively, like an athlete would. Now,
right.
I think about, I think about my parents who they only have 2 knees to replace. So the first one is always their first knee ever, regardless of whoever did it. It's their 8 millionth, right? So, and they're not necessarily worried about performance so much as, am I okay post-op? Like I'll give you an example. I think a lot of people are still nervous. I still hear it in a certain generation about, what do you mean I would have it done at an ambulatory surgery center? And they want to send me home after 3 hours. And I'm like, again, I'm not a joint guy. That's exactly what you want. But, that's how, like, to me, there's tremendous value in that CMS patient, I'll call it for argument's sake, right? That older patient. How do you talk to that person at that backyard then as well?
You touched on a number of points there, right? I mean, I went to medical school in the 90s, right? A lot's changed since then. We know that a hospital's not a great place to be, and you probably want to get out of there as fast as possible. It doesn't mean that people aren't doing great work and trying really hard. It just means there's, all kinds of bad things that can happen when you're, around that environment. And so it would have been crazy to think about sending somebody home, right after a knee replacement surgery. But if you're healthy, turns out that's probably the best thing for you, right? I mean, the fourth most common cause of death in hospital is being in hospital. So it'd be probably wise to avoid that, if at all possible.
I never heard that before, but that makes total
is.
sense. And that would be pretty persuasive.
Well, I mean, the fourth leading cause of hospital death is dying from something you didn't have when you came into the hospital, right? And so, that's really valuable. The second thing is, and I'd really answer it more by telling a story, because I think it's more illustrative than a rule. I can't tell you how many people have come in and said, "Oh, you tell them they're not moving their joint enough," and they say, "Well, I'm worried I'm going to break the stitches, or I'm worried I'm going to hurt the wound," right? And that's perfectly logical. But the fact of the matter is, you do need to move that joint enough. Otherwise, it's going to heal with incomplete movement, right? And to your point, that knee is their first knee. They don't know that. They're going home. They're like, I've had my first major surgery, maybe. I'm trying to baby it. I'm trying to take care of it. I don't want to wreck it. And it turns out that's maybe the worst thing they could be doing. And so by giving them that knowledge, by saying, no, like, we need this much range of motion. You're falling behind. You need to do your PT. You need to stress that joint, which is counterintuitive to an awful lot of people. That's what you need to do. But until you know what you need to do, as crazy as it sounds, when we started this whole journey, we had no idea what normal range of motion was on day 10, or how many steps you'd be taking on day 32. Who knew, right? We just had doctor's notes from follow-ups, and we had anecdotal stuff. But now you can look at that and say, all right, no, I need to up my activity. I'm not doing enough. In fact, the idea that I'm going to come home and rest, which a lot of people do, is a terrible idea. After joint surgery, but perfectly logical to a lot of folks that, that's what they should be doing.
Yes.
So, it's the classic case of knowledge is power. And going back to the diabetes analogy, until you see your blood glucose spike because you ate the bread before you ate the salad, you don't realize, what the correct course of action is. And that, I think, is a really important part. And what we've done is bring that knowledge to the TKA patient as to what they should be doing and when they should be doing it, and how much is enough and how much is too much, right?
Well, then and I thought that was very helpful. And you're right. Like, I remember saying, like, if I got my total knee done today, I get discharged, hopefully today, right? My next doctor visit is 14 days, make sure everything's going well. And then I think my next visit is, and correct me if I'm wrong, I think it's 90 days, 91
it's probably
days.
It's 3 months, right? Probably, depending on your doctor.
So, I mean, I actually think that can be a little scary to people that perhaps I would suspect, since some of my best friends are surgeons, I suspect they might underappreciate what that's like. Night 3 at home, my knee hurts, I'm not sleeping well, or maybe I am. Doc says I got to be doing this stuff, and Doc's not here. And my wife is saying, "Are you sure you're supposed to be?" Like, I think that happens a lot. And to have something in my knee, or like, an internal Fitbit, or however you want to look at it, to tell me how I'm doing and tell my clinician how I'm doing, is a lot better than me wondering or having to call in, right? I mean, that's part of the concept behind this. So you said, tell a story. Tell me the Canary story, right? So I believe I have written down, I think in 2012, is that right? Yeah. You guys founded Canary with, Dr. Fred Kushner out of HSS, I believe, right? And I read that the first thing you did, well, first of all, what made you come up with the idea? And then I want to tell people what I read the first thing you did was.
So, we were talking about this before we went on air. I had been liberated from my previous job. And so I was home, I had spent my first part of my career putting drugs onto medical devices, so trying to improve the performance of devices by adding biologics. And it sounds apocryphal, but it really was kind of like this. I was training for something I don't even remember, and I had lots of time to train, and I was out for a run and looking at my Garmin, and I was, training by my heart rate, and I was, doing things to maximize my cadence and my stride length and all kinds of things. I was, processing this data, and it occurred to me that nobody in the world cared what my last kilometer pace was other than me, but I did care. But I
Other than
did.
you. Yeah.
And I've been working with David McMasters for many years, patent attorney. We've been together since we were kids, through 3 companies. And I said, hey, what's the IP on putting sensors on devices? And my background had all been cardiac. And so actually the first IP we looked at was all cardiac. So I was like, hey, if we could detect pressure and flow in an aneurysm, that would be a life-saving event, because you'd know the aneurysm was leaking, and that would be a thing. Anyhow, fast forward, we looked at all those things. There wasn't a lot of intellectual property on putting sensors into devices. So we started to do that. But it turned out when it came time to make it, this was kind of the smallest thing we could make. And it can be really tough to put that into an aneurysm, right? So we, it turned out that orthopedics was our best shot. And so I called up Fred and, asked him if he was still talking to me, because he had been a shareholder at my previous company. And
I didn't know that background.
In any event, he said, yeah, no, that would be perfect for knees. And, my orthopedic education started that day, as to what to do and why, right there. And it was really that simple. And what it essentially is, and it's progressed a lot. You can just see in 4 years how technology has advanced. But it's a pacemaker battery. It's the telemetry that you use to transmit pacemaker data, except instead of powering a lead, you're going to power sensors, and that was it. So I had a lot of people who'd worked on active implants from my previous life, all from cardiology, which is where most of the active implants live. And so basically we combined those 2 areas of expertise and embarked on a journey of smart knees.
I used to have a CEO I worked with every day, and he would get a little arrogant about it, but he would always be like, hey, Cope, you want to know what's going to happen in spine and ortho? Look down the hallway in the cardiac room. That'll tell you, or whole cardiac service line. He's like, that'll tell you what's going to happen to you. And I don't like admitting it. He was right. He's totally right. So, and for people who couldn't see, Bill was holding up what looked like sort of a spark plug down to maybe a AAA battery, but sort of holding those up. So when he says you can't put it in, you can put it into a knee implant. You can't really put that into certain things that go in and around the heart yet.
We are now.
You guys are doing that. The first thing it said, in this article on MedTech Strategist from about 4 or 5 years ago, it said you and Dr. Kushner, one of the first things you did was put, at the time, this is 2012, 2013, Fitbits on 100 patients, just to sort of do what? What were you hoping to?
We wanted to know 2 things. We wanted to know some of the stuff we talked about. What is normal step count on day 15? And, how active were people? What was the norm? And so that kind of gave us a baseline for what we needed to measure and how much we needed to measure it. The other thing we wanted to address was how compliant are people. So we didn't want to come up with a really expensive way to solve a simple problem. If a Fitbit or a Garmin would do everything we needed it to do, then we needed to go in a different direction. Whereas I didn't think you were going to be able to measure aneurysm pressure with a Fitbit. So before I got into this, I wanted to make sure that we weren't way off topic. And it turned out that only about half the people even use the Fitbit. So a lot of people either never bought it or put it in a drawer. And of the people who did use it, it was pretty sporadic. And so, it's great if your device can detect something, but if you're not wearing your device, it's going to be pretty tough to do that.
Right.
And
well, that's, yeah, if you could
just finish the story. So, only 25% of people made it to day 90. And very few of those 25% wore it for all 90 days. And so it was a human nature problem. It wasn't a technology problem. It was just a human nature problem. So we thought, hey, if we can cement this thing in place and make it, as user-friendly as possible, nothing to wear, nothing to charge, nothing to download, then maybe we'd actually be able to collect a coherent data set, right?
Yeah. I think you drew a parallel in that to antibiotics. And I used to sell an antibiotic, and the best antibiotic is the one the patient takes the full course of. And I think the numbers, I believe, were eerily similar to what had been seen in antibiotic. If you have a pill for compliance, you still will struggle to get people to be compliant with it.
What's the first thing Big Pharma does, right? They go from 4 daily dosing to 1 daily dosing, right? Because 1 pill is better than 4, right? And the second thing they do is to go to some sort of sustained release, so that maybe you only need to do it once a month or once a week, right? Because a lot of your treatment failure is compliance failure. So the same is obviously true in everything in medicine. So
I love it. So when I was looking through your history, so you guys over time, you get in, fast forward about 8 years, you get FDA de novo classification and authorization. You've been already achieved, like I believe, an NTAP, a breakthrough on that, so that reimbursement. I was going to joke with you, Bill. I was going to say, listen, you got well funded, you had great technology. Everybody that looked at you called you a breakthrough, and the United States government even said, we're going to pay more for you. This has probably been pretty easy then. This last decade has been really easy for Canary. It's just, right? Like, and I know it hasn't, but I thought it would be sort of an amusing setup for you to smirk at. So what did you run into? What'd you run into? Because I do think you guys are a success. I just, people are going to look back and say, well, of course they were successful. And you're going to say, ask Bill Hunter in 2022, right? Like, so tell me about what it was like with those hurdles.
For your people listening who are on this entrepreneurial journey, the lesson has been, it's amazing how disconnected things can be. So the science has been incredible. It all worked. And it all worked the way that we hoped it would work, right? The basic theory was straightforward, although more difficult to enact. But the basic theory was, would you behave and walk differently if you had specific problems? So if I know what a normal recovery looks like, well, if you have a blood clot in your leg, will you walk slightly differently? And will we be able to detect that? If you have an evolving infection, right? If you're going to end up with a stiff joint, or you're going to have a limp, or you're going to, have an unstable gait and be at risk for a fall, would that look differently than a person who was walking and recovering normally? Anyways, 10,000 patients and billions of data points later, I can tell you that's absolutely true. And you can find it. Just like a cardiologist uses a Holter monitor to pick up very subtle changes in the way that the heart beats and say, oh, that's a structural heart problem. Oh, that's an infection. Oh, that's ischemia. By looking at an electrical wave, you can diagnose things that are not electrical just by seeing how the heart adapts to these different pathologies. Well, gait is like that too, right? If you have Parkinson's disease, I guarantee you walk differently than someone who doesn't. And we were all taught all these gait abnormalities, but we never had a gait monitor. We never had a Holter monitor for gait. And it turns out we do. And so the science has been absolutely crazy. It's been one of the funnest things I've ever worked on in terms of harvesting these things to find that. Now take that and put it off to the side. Commercially, it has been absolutely challenging. And if I had to distill 1,000 lessons down to one, it would be that changing the way that people practice medicine is very, very difficult. So, every orthopedic surgeon I talk to, understands that their role is to restore normal function and movement. So us monitoring function and movement makes absolute perfect sense. It's not like there's any, every single one of them sat through the same lectures I did, where we looked at, Trendelenburg gait and heel drop and, everything else. So they understand that a change in gait could very well be, diagnostic of a particular problem. Understand all of that. But how do you take this thing and incorporate it into practice? So I now have a whole new data stream that I've got to look at, I've got to interpret it, but more importantly, I've got to use it to make a therapeutic decision. And that therapeutic decision has to, in today's world, yield two outcomes. One, my patients have to get better than they would if I didn't have it, right? Excuse me, three things. Two, it's got to cost less than, what I'm currently doing. And three, it better be less work than what I'm currently doing. And those are, those are things that you have to enact. And those are changing the way a human being practices medicine. That's a much longer way of doing things. Holter monitors are a great example. They also took 50 years to become mainstream in terms of cardiology, right? So, they make great sense now, right? Looking backwards, first thing you do to somebody who's, got a cardiac abnormality, send them home for 3 days so you get an idea what's going on. Makes perfect sense. But it took years for that to become, standard of care, to change the way that people examine the cardiac patient. That has been the challenge, right? It's been, okay, how do we operationalize this? Like, how do we turn this into a way of caring for our patients?
Well, you had mentioned, I heard you on a different talk saying, and I found this fascinating. I remember, I will remember hearing this being said by you going, you could, light bulbs going on when you said something to the effect of gait is a vital sign, or at least a biomarker for multiple disorders. And when you say it the way one of the reasons I enjoy talking to you is you describe these things, and I could be your neighbor, and I walk away going, I know exactly what he means, but I never thought of it that way, which I think is sometimes maybe part of the problem. Many of us never thought of it that way. So could you give an example of what you mean by that? And then we'll hit number two, the cost thing too, because I love how you describe the costs of total hips and knees from a large global picture. So, but tell me about that if you would. Gait being, let's call it a vital sign.
Sure. So I'll give you a totally abstract example, and one that has nothing to do with what we're trying to achieve commercially. So if you look through our patient data, we found that we have almost 400 people who have Parkinson's disease, right? And that's not surprising. It's about 5% of the population over 60. Yeah, it's about 10% of the population over 70. So we've got a bunch of people with Parkinson's disease. Anyone who's known a patient with Parkinson's disease will tell you their gait is dramatically different than, a person who doesn't. Okay, so I've got a total knee replacement. How in the world could that be relevant? And you would immediately think not. So, but it is. My left winger, when I was a kid playing hockey, is now the head at UBC. And he said, you're incompetent and should never be in the field of, but let me explain it to you like you're a 3-year-old. So this is what I do in Parkinson's clinic, right? I have the person in. So first off, suspected Parkinson's movement disorder, I watch them walk, and then I do an MRI, right? And I find is that by the time I diagnose that person with Parkinson's disease, neurons and their substantia nigra. And wouldn't it be great if I could diagnose them earlier, because maybe I could attenuate their disease? If I got them at 50% or 40%, maybe I could have their disease-free status last much longer by trying to manage that. So put that in the back of your head.
Yeah.
He goes, all right, so now I have a patient who has Parkinson's disease. How do I manage them? Well, I use levodopa. I replace their dopamine. How do I dose that? It sounds an awful lot like how I took care of diabetics years and years ago. The person comes in, I watch them walk. And if they're walking poorly, I up their dose. And if they're showing side effects, I drop their dose. That's how I do it. That's how I do it.
Decrease.
And they may be having a good day. They may be having a bad day. They may have taken their medicine on time. I don't know. Right? But imagine now continuous glucose monitoring. What if I was looking at their gait all the time? And what if I could follow them? And so when they took their levodopa, I could see how their gait improved. I could see when it dropped off. I could figure out when to dose it, how much to dose it, how frequently to dose it. Welcome to CGM for Parkinson's patients, right? We are definitely not the first people to think of this. There are people making wearables and doing all kinds of things for early diagnosis. But now I've got this database. What if I figure out from this knee, what Parkinson's gait looks like? What if we scanned all the other 10,000 patients to see if anybody was showing early signs of that? Maybe we could diagnose a whole bunch of people with early Parkinson's disease. In any event, that's a long-winded way of saying that gait is a fundamental aspect of your health, right? To walk upright, you need an intact musculoskeletal system, neurological system, cardiovascular system, and respiratory system. If any of those things are not working, it manifests itself in your activity and gait. And with precise enough gait information, you can look at a lot of different things. And so for people developing products in anything, the take-home message is, if you can pull out a continuous data source from inside the human body, I guarantee you'll be able to do something with it. You know, if I have pressure and flow coming from the vascular system, I'm going to be able to do an awful lot with that, right? If I have imaging coming from the human breast, that's actually going to be pretty impactful if I've just done a lumpectomy or a cancer resection surgery, or, you know, if I can tell if there's bleeding inside the human body, I can think of 100 different ways it would be important to measure and monitor that. So the take home is, right, just having these continuous physiologic vital signs allows you to do an awful lot in medicine. And it's, you know, we're just seeing that with gait, but that principle should apply across pretty much any type of medical device you can think of.
Let's take a break for a minute and talk to our sponsor, me. This podcast is brought to you by me, Mark Copeland, the Value Analysis Whisperer. Have you ever tried to get a new product, your new innovative medical device, approved in an ambulatory surgery center or hospital and failed? Have you ever thought about the amount of patients who can't get access to your innovative medical device because you can't get it approved? Have you ever thought about the clinician champions of yours who are frustrated because you and your company can't get your new product approved where they work? Of course you have. We all have had that happen. Here's the difference. Are you ready to make a change and do something about it? If so, go to my website, valueanalysisexpert.com, and click on some time with me, Mark Copeland, the Value Analysis Whisperer. You can do this. I will help. Now, back to our podcast. Bill, I've heard you say this 3 times now. And every time you say it, I think, how have I not heard about this more places? And why do I not hear about it when I hear people? I know why I don't. When I hear people presenting about the product, but I mean, in facilities. Yeah. But that's which leads to my sort of my question about cost. You, I remember on Tiger Buford's chat, you showed that, I think I have this right, approximately 75%, I think it's 3-to-1 of the costs in a 90-day global of a total knee are after surgery, and it's the rehab, it's the it's sort of everything that goes along with the recovery versus the actual surgical procedure, implants, all that. Could you talk a little bit about that? Because I found that fascinating, and so did everybody else on that call.
So Believe it or not, the data on this is weak. We went through 1.4 million Medicare patients. And so I'm only now starting to have private payer data, but I only have Medicare data, which is skewed, right? On average, it's about half of what the private payer costs are. But for Medicare, for example, it's about $12,000 to put a knee in. But you'll spend $16,000 looking after that knee patient in the next, 18 to 24 months. And in fact, you'll spend $5,000 in the first 90 days. You'll spend $5,000 in the rest of year one. You'll spend $5,000 in year two. And what you spend it on is fascinating. We can talk about that as well. I now have the insurance data coming in, the claims data from our patients. And I know, for example, that, blended all in between Medicare and private payers, it's, you're spending roughly $10,000 in the first 30 days. Or excuse me, the first 90 days. You're paying $10,000 in the first 90 days. So you're almost paying the entire cost of surgery in the first 90 days.
Okay, so my numbers were off.
No. It's going to be close in 2 years. It's going to be close to 2 to 3x the total cost, and that shouldn't be surprising when you actually break it down in your brain. But it is surprising when you hear it for the first time, because people get X-rays and MRIs, and they get home care, and they go back to the emergency room, and they get readmitted for a whole bunch of other problems, and they have step down care, and they have PT and right. And it's not surprising to most people that looking after a surgical patient 9 times out of 10 is far more expensive than doing the surgery itself. But because we're in the medical device industry, 100% of our energy is focused on how much am I paying the doctor and how much am I paying for the implant, right? And how I look after that patient, well, that's a whole bunch of stuff I can't even think about, because that's nurses and X-rays and home care and PT. I'm not even going to think about that, right? So embedded in that is the answer to your first question. Why does it take so long? Why is it hard? Well, because you're not saving any money. In fact, you're adding to the cost at the beginning. You're not saving any money on the surgery or the implant. Right. And in fact, you're not even making it better. You're not doing anything for that. But what you're doing with monitoring is taking a bite out of that care cost, right? CGM is not about making a better insulin, right? It's about managing a diabetic better,
right?
And saving the costs of patient management. Very rarely do medical device companies think about the cost of patient management. They think about the cost of the procedure and the surgery. And so we are actually not in the medical device business. We are in the patient management business. Right. And that's a different market with different payers and different financial incentives. And it took us a while to figure that out. And well, we're still figuring it out.
Yeah, but I'm guessing that means a pivot. Mm-hmm. Well, I know it does. You're pivoting towards insurers, because they're the ones who are at part of this, who are more aligned with that longer term cost of patient care management, right? I mean, that's kind of where it naturally leads, I would think. How successful? How do you feel like that's going? I know you're.
Yeah, I'm kind of knee deep in that right now. So a lot of our problem, for lack of a better term, was math, right? In order to do all these crazy things, you need to have years of follow-up, and you need to have tens of thousands of patients, because at this point now you're dealing with kind of population management, right? You're not saying my knee is 14.3% more effective than the competitive knee in a head-to-head program. So it's a very different ballgame. And you're looking at very different endpoints. Did a human being get readmitted? Yes or no? Did a human being end up with a blood clot? Yes or no? Right. And that's a lot of follow-up. And so we now have that data, but I've only had it for 5 or 6 weeks. And now we are in a position where we can sit down with a payer and say, look, a monitored patient stays out of the emergency room, just like they do in cardiology, just like they do in diabetes. A monitored patient is much less likely to be readmitted. we even talked about that earlier on, right? If I know that what I'm experiencing is normal and my partner's harping at me to go to the emergency room, I can say, hey, look, no, I think everything's okay, right? I mean, what percentage of ER visits are for reassurance? 50, 60, 70? I don't know. And so, these things all work, but it's very different than the traditional medical device study, right? And so that's what we need to do. I believe we need to sit down with payers in the very near future and say, look, we can manage your TKA patients just like you manage your diabetic patients. And a managed patient does better than an unmanaged patient. And the way you're going to recognize that is lower imaging costs, lower readmissions, quite different than the primary endpoint of a TKA study.
Right. Right. But I want to back it up because I actually think, there's a great song I think it's the Water Boys, where I see the part of the moon, you see the whole, right? And you just described the whole of the moon. And I think, but the whole of the moon sometimes requires big data sets, big payers, and time. And in the meantime, you're a business. And at least, I don't think you're a 501c3. I'm pretty sure you're a business. Your investors are certain of it. And what I have always wondered is, does your product, if you put it in my knee and you put it in the next 50 of patients, do those 50 patients, or 100, if you want to make the math easy, are those 100 patients, generally speaking, less likely to need to come back for a second or third clinic visit or ER visit because you're capturing me sooner? Maybe less fun, maybe better yet, an ER visit becomes a clinic visit becomes a phone call that maybe doesn't happen. And I would think that helps my clinic and my business unit treat patients better and see more patients. But am I just
no, you're right on top of it, actually. And unfortunately, it's not a really simple answer, but an answer does exist. Excuse me. So, and it goes down to the numbers, right? 85% of patients are going to recover from TKA largely without incident. It's a very successful and operation.
Yeah.
And so, unfortunately, the way medicine is practiced in general is that we've come up with these standardized plans of how we handle all our patients, good, bad, ugly, right? And so you could legitimately ask the question, do those patients doing really, really well? If you're doing thousands of steps every day and your range of motion is normal, and I take an x-ray of you, chances are that x-ray is coming back normal, right? MRI, most x-rays do come back normal in TKA, and yours is probably definitely going to be normal when you're asymptomatic, right? And am I really benefiting from home care? 70% of Medicare patients get home care, but if you're doing really, really well, are you getting any benefit from that, right? Once you've done your initial PT, if you're really active and you're doing great, is additional PT may be necessary in that condition. So for 85% of patients, you run the risk that you're over intervening and over treating, and doing things that have a very, very low likelihood of generating a negative, diagnostic.
Right.
But then the opposite is true. Your bottom 30% cost a lot. That's where your cost lives. And by the way, that's where most of your non-compliant patients live. They're the ones who are
that's not coincidental. Yeah.
And so if I could monitor those patients and I could see where they were doing, and I could send home care to somebody who's been on the couch for 3 days and is not doing well, and if I could focus those precious resources on the people most in need, could I prevent the $14,000 hospital readmission or the $3,000 to $4,000 ER visit, right? And so the answer is all of that is possible, but your question, as you can see, requires a very integrated approach to realizing those gains. But you've been doing this for a long time. I've been doing this for a long time. Most medical devices are pretty damn good. And the opportunity to improve efficacy by 50% or reduce cost by 50, 60%, that was years ago. Right? Yeah. Now we're kind of looking at relatively small improvements by improving the devices. But this patient management piece, which has largely been done, I hate to say it, by word of mouth or best practice or whatever, but hasn't really been analyzed down to the, tiny details. There's enormous opportunity to intervene in there. When people ask me about digital health and remote patient care, that's where, that's the untapped market, which is matching the right treatment to the right patient. Because right now what we do is every patient, for the most part, and you think about almost any surgery you can think of, any minimally invasive procedure, the follow-up is the same for every patient. You get handed a sheet and you do this. Right. I mean, that's exactly what happens. Yeah. And I think intuitively we can all sit there and say, all right, a morbidly obese diabetic is going to follow a very different recovery pathway than a fit, healthy, younger patient. And yet we treat them all as if they fall under this one blanket. And so the cost and the efficiency and, quite frankly, the efficacy opportunity is really in post-operative care. That's where you can move some really big numbers.
Yeah. And those are big clinical numbers and big financial numbers that, it's interesting. I think what I've learned from being around small, forward-thinking, innovative companies, and you're a perfect example, is sometimes, and I'm not saying you are, but I have found some founders being so guilty of seeing the whole of the moon that the first step is almost sort of, let's not worry about how we optimize those 100 patients. Let's worry how we prevent the 30%. Like, how do we know about them a little bit sooner so we can prevent it? And then once we've maximized that, then we really start to optimize. And I just see a lot of, I think that's a sort of the visionaries struggle because they see so far down the road sometimes. But hey, you have mentioned a couple of things.
No, I'm actually okay for time
here.
Yeah.
Oh, good. Okay. Well, I'll steal you for a couple extra minutes if possible. You have mentioned a couple of things. I always like to ask people, what have you? I think you're a very humble guy, but what have you learned that you didn't know? And then what have you? You've told me some of the things you confirmed. You're sort of like, we knew this, and now we've sort of proven what we knew about gait. You have mentioned at times that cardiac was driven by data. You were in it forever. And when you came out with a clearly better thing, the market would swing to it. And I have friends who were in that business who would say, I'd have 3 great years, and then my competitor would come out with something better. But you've described that it's not the case in orthopedics, at least. So could you just talk a little bit about that?
Yeah. So what you talk about lessons learned. Yeah.
Without upsetting anybody.
You talk about lessons learned. I mean, I've learned something really valuable about myself. That, I am a scientist at heart. And, I am most interested in doing projects that result in meaningful clinical benefit or meaningful discovery. What I'm clearly not good at is being cognizant of whether that discovery is going to translate into economic value. And you and I have participated in discussions about whether you follow the science or whether you follow the market opportunity. I am clearly one of the follow science guys. What that does is it helps you discover new things, and that's really fantastic. But sometimes you have a solution without a market problem. On the other end, I think it's great to go identify an unmet medical need, but you also got to figure out how to fill that need. Yeah. They both have their right. weaknesses. But the reason I give that preamble is you're also who you are is what you've been through in life. And I spent a lot of time in interventional cardiology, and in interventional cardiology, she with the best toy wins, right? When we made the Taxus stent, and the drug-coated stent was much better than an uncoated stent, we took 70% of the market in 70 days. That type of market shift is never going to happen in orthopedics. But in cardiology, there's no brand loyalty. And I don't mean that as negative as it sounds. If there's a better product, a better care, and you used to be a, Medtronic user and Boston Scientific's got the new thing, you're going to try the new thing. It's just, it's how that works. Orthopedics, I learned, is so very, very different. I mean, doctors, came out of residency as Stryker docs or DePuy docs or Zimmer docs. And the impetus for change, even if you have a truly differentiated technology, market share moves by 1% and 2% per year. You don't see these massive shifts. And there's probably a whole bunch of layered reasons for that, including the fact that there aren't massive changes in efficacy either. So there's not really an impetus to, throw everything out and start anew but you do need to understand that a culture evolves around that. In cardiology, there is a willingness to try new things, to experiment, to push things. In orthopedics, where, let's face it, hips and knees particularly hips, you get really great results. And you've been doing it this way for a long time, and you've been getting really great results. You're not going to just suddenly, some guy like me comes in and says, hey, you got to try this. You're going to take a much more skeptical approach to it. So there really is a cultural difference. But there's also an efficacy-driven difference as well. And I do laugh when people push MedTech into all being in this one basket. It's not. There really are substantive differences in the different practitioners and how they approach innovation.
Yeah. Well, the people who have been in both, and I can think of 3 different people that I know of that have been in both fields, say you're one of them, say that something eerily similar. And it's neither good nor bad. It just is. And if you're not prepared for it, like it can be a shock.
And apropos what you do for a living, and you also have to address it very differently. Going into an interventional cardiologist, it's data, right? We did a head-to-head trial, this product versus that product. Here's what the Kaplan-Meier looks like, right? Orthopedics is going to be a very different approach. It's going to be like, all right, so we did this, which led to that, which led to this, which, ultimately went along that pathway. And in fairness, and appropriately so, they're going to say, all right, well, I'm going to try this in a few patients and see how it goes, right? They're not going to say, all right, I'm switching over. That's just not real. And if they spent millions of dollars on a robot that works with their particular implant, then, that's a whole separate podcast, right? So,
Yes. Yeah. Well, so I have 2 questions for you. Number one is, what's next? It looked like you have done some cardiac now, getting back to it. You're not just a smart knee, you just happen to be, it seems like, a smart knee today. But what's next for you?
Yeah, guys? I mean, if I was persuasive enough to get SoftBank and Sequoia to give me $1 billion, there's an endless number of things. Sensors have gotten much smaller, much better. We now have chemical sensors that can do glucose and electrolytes. We now have, MEMS ultrasound where you can do imaging, and truly, if you let your imagination run wild, you say, all right, if I was going to put sensors on a heart valve, what would I want to measure? If I was going to put sensors on a coronary stent, if we built a coronary stent tomorrow that measured pressure and flow, and I could tell whether your stent was open or closed without doing an angiogram, we'd have 100% share in about, a month. So
as long as it can take for you to get out and tell everybody, right?
So, if you look at any medical device and you say, all right, if you had a continuous, meaningful physiologic data stream coming from that device, would I want to know if my spine was fused or not? Probably, right? So these they're not rocket science. And so, what I would love to do is progressively put more and more sensors on more and more different devices. The reality is that there's not enough money and enough time to do that. But I will, after I retire, I will be cheering on all the entrepreneurs that continue to do that. But, in cardiac, pulmonary artery pressure is really, really an important thing. Right now, we can only do it by instrumenting the pulmonary artery, which is complicated, and leaving a sensor in the pulmonary artery, which is complicated. There are ways to do that without being in the pulmonary artery, and that's one of the things we're looking at. I'm interested in breast. When a woman has a lumpectomy, we leave markers behind, because if it turns out to be malignant, we want to be able to find it, or we want to preserve anatomy, or whatever the case may be. But we also know that a significant percentage of those women are going to have a local recurrence of their tumor. Wouldn't it be great if we could image that? And if we could have a monitor that was able to do that? So cardiovascular, I'm interested in, because quite honestly, if you have pressure and flow, everything else is math. You can calculate cardiac output, ejection fraction, everything else. I'm interested in bleeding. So whether or not, you have ongoing bleeding versus clot is pretty important in surgery. It's pretty important in aneurysms. It's pretty important in a lot of things. And I'm interested in imaging, because that's so each of those things we have active programs in. And that's where our money is going to go. I think we often get thought of as a orthopedics company or as a motion company, but again, I don't want to take up any more time, but strangely enough, everything we've learned about movement, well, putting all that into a cardiac device is actually pretty important. If I know if my patient's sleeping upright versus sleeping flat, that's actually pretty valuable. If I know that my patient is active and moving around, that's pretty valuable. If I have enough gait information to know that my patient has claudication, that's actually really valuable. And so as you get these different capabilities and you start to mix and match them, I think 5 years from now, 10 years from now, the concept that every medical device will provide a lot of meaningful real-time feedback, it just has to happen. And that's really, that's the passion project.
I love it. What's the advice? Is the last thing I'll ask you. What's the advice? Don't give yourself advice. I mean, I read your stuff on LinkedIn. I love it. What advice would you give to the first time medical device or entrepreneur that you wish somebody had told you back then? Like, what do you say to this? Because I know you talk to a lot of folks. What do you tell them?
So I give them somebody else's advice and then I'd give them mine. So the advice I didn't take in my career, and I have seen executed beautifully by many entrepreneurs. So if this describes you, do not follow anything I say, because I will lead you astray. There are a lot of people who've done a masterful job of taking a device, understanding it, talking to the end users, improving it, incrementally improving it, developing it, selling it to a major, and then shampoo, rinse, and repeat. Go back and do it again, right? And that people with a lot more money than me have done that tremendously successfully. And by the way, the world needs that, because continuous improvement of those devices is a wonderful way to spend your life, and it's a good way to make a living. Clay Christensen would call that classic sustaining innovation, right? Just improvement and continuous improvement. If you're not genetically gifted like me and you follow stupid things, go the other route, which is true disruptive innovation. But accept the fact that failure will be a major part of your life. Big swings result in a lot of trips back to the dugout, right? But when you hit it, it can be a beautiful thing. but you have to arbitrage your career accordingly, right? You have to finance your career accordingly. You have to set the expectations of your career accordingly, right? You may spend an awful lot of time on a project that really should work and doesn't. And you're just going to have to accept that, you're going to have to go back and adjust your swing and face the next pitcher. You really do. And I love doing that. And I was very fortunate that I got to do that. But, and people will talk about the stent, and I hope someday they talk about, smart devices in the same breath, but I've blown up $1 billion a couple times too. Right. So, you have to be, prepared for that. And I think you got to do an honest assessment of how much risk you can live with, and how much risk the people in your life can live with, and how much up and down you can tolerate, because there's different ways to be an entrepreneur in this business.
Well, it's one of the themes of this season's shows, talking to people like you, is many of us have chosen the path of most resistance, is because that's what it seems like. And I'm not really sure why or what that is, but you just really explained it. There's to an extent as to what it feels like and how to, I like that term, arbitrage. It, listen, I could talk to you all day long, but I'm not going to do that to you. My only question was, and I may edit this out, was you're a smart Canadian hip guy, and I can't get you to call your hip implant the Magically Hip. I mean, it's right off of Canada's greatest band. And I don't know what I have to do to persuade it.
That is fantastic. And as a guy who knew Gord Downey and grew up in the Toronto bars, going to the Horseshoe Tavern, watching them play before they progressed beyond, that would be a wonderful tribute to him,
wouldn't it?
Unfortunately, as the small,
I wouldn't listen to me
partner in the partnership, sales and marketing is in the hands of a much more sophisticated and talented group at Zimmer Biomed.
I suppose I'll accept that as a reasonable rationale for not doing it, but I knew I'd get you to laugh if I brought it up. So listen, thanks. I'm rooting for you. I just think what you guys are doing is great. I want one in my right knee when I finally decide to go get one, and my surgeon does not use Zimmer Biomet, and he and I are going to have a discussion. But I love what you're doing, and frankly, more importantly, I really like how you do it. I like how you talk about it. I certainly appreciate your humility, although I don't think it's really warranted. And let me know if I can ever help. But I think what you guys are doing is, we're all going to look back on it and say, "Oh yeah, remember? Was that so obvious?" And you're going to be on a rocking chair going, "No, it was not. No, it was
it's
not."
It's funny, we back in 1992, we wrote a bunch of patents on paclitaxel-eluting balloons and for peripheral vascular disease, but we also believe that they could be used in prostate to prevent, restenosis after a BPH balloon, and we also believe that they could be used in inflammatory bowel disease for strictures and all kinds of things. And in fact, we tested them in all of those models, and for a whole bunch of commercial reasons, didn't do it. But both those products now exist, and believe it or not, I take as much satisfaction in having been there for the birth of the baby, even though I had absolutely nothing whatsoever to do with, the kid getting his PhD. It's wonderful. I mean, it's a great business. How many $1 trillion healthcare companies are there? None.
I mean, I don't even know. I don't think
they're all tech companies, right? So if you want to make money, go into something else, right? Right? I mean, who's the biggest market cap company right now? It's usually Medtronic, but it might actually be Dexcom or something for all I know, right? Or it might be Intuitive, excuse me. for all I know. But the biggest healthcare companies are peanuts compared to Amazon and Microsoft and whatever. And the reason is because it's a really, really tough business. But it's a great business, right? Like it's a wonderful business, but it's super hard. And then that I think is part of its magic. It's super hard.
Yeah.
But that's great.
It sounds like that's why you kind of like it. I mean, I know
Yeah.
you're a doctor by training. You're helping people by the 100 and 1,000 ultimately as you're getting this. And I would imagine there's a tremendous amount of satisfaction in that. And I don't have that. Like I can't say I do that. I'm just one of the people there that's supposed to be able to help those
But
people.
it takes so many people to make something work in our business, right? That's the other beauty of it, right? It's not Mark Zuckerberg, refining social media. It's hundreds of people, expertise in all kinds of different things to get something across the line. But what I love the most about it, I'll write a post on this someday, is that biology is a wonderfully objective evaluator, right? You can be the biggest company in the world. You can have the most resources. You can be some guy in a basement lab working on atrial natriuretic factor, right? But if you're right. And biology decides. And a big company you can't outspend, you can't outmarket biology, right? You go into a trial, you win or you lose, right? And I love that. It is kind of the track and field of the world, right? Somebody crosses the line first. The clock doesn't lie, right?
The eye in the sky doesn't lie.
There's a winner and there's a loser, right? And there's somebody's faster than another, and that's just what it is, right? There's no judging, there's no umpires, there's no referees. It's totally objective, really. And I love that about this business.
Now you see why I think Bill Hunter might be the most interesting man in med device, let alone orthopedics. I'm fascinated by this. I've been following him for quite some time. And I think this is the future. You can argue with me. Feel free. But I'll bet we're doing more of this in 15 and 20 years, not less. I'm Mark Copeland. I'm the Value Analysis Whisperer. This has been How I'm Building This by Sutures and Cents, my podcast. And if you know an interesting inventor, founder, CEO of a small med device company who you think might be interesting, they don't even have to be as interesting as Bill Hunter. But if you think they're interesting, send them my way. I'd love to talk to them, and I'd love to hear how they're building their small med device company. See you next time.